Hello, and welcome to our webcast. I'm Amy Pendergrass with Moss Adams, and I'm going to get us started for today's session, 2021 State of the Union Healthcare, featuring Koles, Vice President and National Spokesperson for the Advisory Board. This is the first session of our virtual 2021 Healthcare Executive Webcast series. More information on our conference and sessions is available in the links provided in your console, as well as on mossadams.com. Before we begin, I'm going to play our housekeeping video.
Welcome, and thanks for joining us. We're pleased to present another in our ongoing series of continuing professional education webcasts to help companies and individuals conquer challenges as they plan for what's next. Our presentation will start in a few moments. Before we begin, here are a few things to keep in mind. You can customize how you both view our presentation and interact with the presenter. For better viewing, close all other applications and turn up your speaker volume. You can also adjust window size and placement or enter full screen mode using the controls at the top of the window or dragging the bottom right-hand corner to resize. At the bottom of your screen, you'll see a series of icons, each relating to a different aspect of our session. You can download the group attendance sheet and a PDF copy of today's slides from the slide deck and handouts widget to the right of the slide view. You can ask our presenter questions during the webcast by typing a question in the Q&A window below the slide view and clicking Submit. We'll do our best to answer all questions during the presentation or follow up via email. If you experience technical difficulty during today's presentation, refresh your browser by hitting the F5 key.
All right. Today's webcast is eligible for 1.5 CPE credits. For the National Association of State Boards of Accountancy, to qualify for these credits, you must attend for a minimum of 75 minutes and respond to at least 5 of the 6 polling questions. The presentation you're about to see isn't legal, investment, or accounting advice. We encourage you to seek the counsel of a professional service provider to apply this content to your specific circumstances. And with that, I will turn it over to Brian Connor, Partner and National Practice Leader of Hospitals at Moss Adams. Brian, the floor is yours.
Super. Thank you, Amy. Appreciate it very much. And I just want to say welcome to everyone and thank you for joining our Moss Adams 2021 Healthcare Executive Webcast series. I'm Brian Connor, the Hospitals and Health Systems National Practice Leader for Moss Adams and MC for our conference series. It's the 26th year that we're hosting our annual conference. Ford and I are wearing ties today, in fact, and pants. I am, at least anyways, to commemorate this milestone and hopefully as a harbinger that we'll be back together in person for this discussion soon. This year, we're welcoming almost 1,200 attendees from across the healthcare continuum. We welcome lots of newcomers to our series this year, as well as many of our honored clients and longtime professional associates. As always, our objective is to convene executives and members of the C-suite in healthcare, from providers to payers, for robust policy and healthcare environment discussions, as well as having folks from life sciences, tech, private equity, even the forest products industry and breweries. We are delighted to welcome all these employers who are also very vested in the current future state of healthcare, especially as it relates to the current rising costs of healthcare, the impact it has on recruiting and retaining employees, as well as impacting our overall health and well-being. This year, we decided to shorten our series to 3 high-impact sessions. We also made this year's event complimentary, which I'm sure had very little to do with our increase in attendance, but rather is one way to say thank you to all of those in the healthcare industry who've endured 18 months of the global pandemic and the subsequent consequences of that pandemic. From first responders to nurses, doctors, healthcare providers, staff, executives, all of you in the trenches, hats off. And we appreciate all that you continue to do. And now today's session that sets the stage for the current state of the union for healthcare. We welcome back Ford Koles, as Amy noted, of the advisory board to address key opportunities and challenges for the healthcare industry and steps that you can take in the aftermath of the COVID-19 pandemic to prepare your organization for 2022. Although we can't see you, we do welcome your participation and encourage you to submit questions throughout the session. We'll, of course, do our best to answer these questions after the discussion. We got a lot of information packed in here, but we'll get to as many questions as we can, and your participation is really critical in helping us deliver an engaging and thought-provoking virtual conference. A couple of housekeeping items. Please note a few things on your webcast console. We have provided you with several links. Please be sure to leverage these links at your leisure, including links that have a download of the PDF of today's presentation, a link to our healthcare industry insights page with healthcare-related content insights that offer a broad spectrum of commentary and solutions for accounting, tax, finance, business operations challenges, et cetera, et cetera. So please take a look at that. And of course, you can subscribe to receive customized Moss Adams content. So without further ado, I'm delighted to introduce today's speaker, Ford Koles. Ford is one of the best known and most requested public speakers in the healthcare industry. He's the Vice President, National Spokesperson for the Advisory Board, and one of the Advisory Board's preeminent thought leaders in the area of health system economics and strategy. He heads the faculty of the annual series of Chief Executive Officer meetings, and he's certainly sought after to address significant reform initiatives, including expansion, vertical contracting, physician partnership models, managed care, payer contracting, horizontal integration, and system economics of scale, as well as quality-based payments. So again, we're delighted to have Ford back. And Ford, the floor is yours.
Thanks, Brian, and really appreciate Moss Adams inviting me. This is always one of the most interesting conferences that I do every year, and I couldn't be more excited to get back in person with all of you in the future at a location yet to be named. Brian, looking forward to that. I thought I would just give you a quick overview of where I want to take this. See, Brian, am I forwarding here? It's not forwarding. I do something wrong.
I'll forward for you, and then you should be able to. Let's see.
I don't know why it's not doing that.
Well, it wouldn't be. Yeah, I can.
I'm not seeing it.
Currently.
Why am I not seeing the slide?
Huh. I have a picture on my slide of a conference. It might be a picture from a World War II era conference.
Yeah, that's it. But I don't understand why I can't see it. Huh. What does that mean? Hold on. Let me try it one more time.
Might be a hit F5 moment.
Let's try it. Yep. My God, you're a genius. You're a genius. It worked. All right.
And on we go.
Back. Actually, let me go back one here. Okay. So I wanted to just bring your attention to the subtitle of today's conversation. We called it a generational opportunity to reshape the industry. Moss Adams, as you know, is one of the best of the accounting and auditing firms. They do great work, but I'm guessing that's a practical bunch. My accountant is a practical person. So I'm guessing that sounds a tad dramatic to most of you. But I do believe that's an accurate description of where we sit right now in this moment in healthcare. I know the past year and a half was terrifying and life-changing and challenging in ways far too numerous for us to walk through this afternoon. But I'm ironically going to argue to you today that it is the next year and a half, not the last year and a half, that is going to determine the future course of the healthcare industry, regardless of where you sit, whether you're a payer, health plan provider, or any of the above. Many of you know I like to start my conversations, Brian already showed me that slide, with an out-of-the-industry analogy. When I looked around for something to capture this moment in healthcare, there was honestly only one image that came to my mind, and I have it here. I'll give you Churchill, Roosevelt, and Stalin. For anyone who fell asleep in ninth grade history, this is the Yalta Conference. This is the U.S., the U.K., and the Soviet Union, the second meeting between the superpowers, the Allies, to discuss the prosecution of World War II, but also to begin to discuss the peace and the reorganization of Europe as well. Remember, this was the point in the war, the point in World War II, when there was no great mystery left. Everybody knew how it was going to end. Germany and Japan were on their last legs. But I would remind you, the war was not over, right? There were still a few surprises, for example, nuclear weapons, which was surprising to at least 2 of the 3 people at that meeting. So these 3, that's what reminds me of COVID, by the way, is I think we all know how COVID is going to end. I think we all have a pretty good idea about that and the vision of it. But of course, COVID's not finished yet. We're not finished with it, and it's not quite finished with us. But I think, we all have a pretty good idea of how that will end, which is why I think of Yalta. These 3 were eyeing each other nervously, and they were talking about the war and how to finish it. But they were, again, also beginning to talk about the post-war order. If you look at newspaper articles and surveys of 1945, the whole world just wanted to go home. Everybody, after 6 years of slaughter, everybody just wanted peace and normalcy, as we call it. If you look at the letters and notes of these 3 people, they were acutely aware of the fact that that would never be the case. They were consciously meeting not to return to the old world or simply to rebuild it as it was. They were meeting consciously to establish a new world order. And this goes back to my COVID point, what even they didn't realize in the moment, if you look at their letters, is exactly how consequential Yalta was. In other words, they thought that they were deciding something that would last for a few years of geopolitics. What they had no idea is that they were establishing a system that would basically last until the Berlin Wall fell down in the early 1990s. And they had no idea that that was the case. It is not abundantly clear where I'm going with this. I'm sure it probably is. I would argue that you, as leaders, are effectively the 3 people in the photograph at this moment in healthcare. I will let you pick which of the 3 you most identify with. Obviously, Brian, I'm hoping you're not choosing Stalin. Because the decisions that we're facing right now, they hopefully won't launch us into a new Cold War, but I think they will have profound implications for the future of healthcare. The people in this conference, the leaders, the C-suite leaders in this conference, are right now making decisions that will transform everything from the future of virtual care and home care to the industry's trajectory in physician alignment and risk contracting. And the attitude with which we approach these things, as usual, is critical. So let me propose right here up front that you and I banish 2 phrases, these 2, from our lexicon. I'm going to acknowledge them now, and I'm going to do my best not to use them in the course of this conference. Please call me out if I do so. First on the left is the new normal. I'm guessing you're as sick of this term as I am at this point, but I'm sick of it because I've used it over and over and over. And this is why I don't like it. It suggests that the future of healthcare is somehow fixed. It's written, to paraphrase Lawrence of Arabia, right? And if this is the way we think about it, then your main responsibility as leaders is to figure out how to adapt your organization to what is a pre-existing reality. This was the term I heard all the time in the early months of the pandemic. Over time, more people that I work with have gravitated toward the term on the right, which we call the recovery period or the recovery phase. The longer the pandemic dragged on, the more political it became, the more exhausted we all got. Frankly, the more attractive the pre-pandemic norms of healthcare began to look. In this vision, your main ambition as leaders is to facilitate and hopefully speed up a return to that world. My point to you is that I don't think either of these is helpful because both of them cast you as leaders as essentially passive actors. Again, to my point, they assume that the future is set and that your job is to effectively steer your organization, your company, into that future. But think back for a second to the decision points that we just talked about. home care, virtual care, alignment of physicians, right? Health equity and a million other things. As long as these questions are unanswered, and I hope you would agree with me that they are unanswered, then there is no way that the future is set. So the question that we should be asking ourselves, I put it at the bottom of the bold box there at the bottom, is not what does the future look like? It's what do you want it to look like? Right? We are on the cusp of a third phase of this terrible pandemic. Phase one, to go back to my wartime analogy for a second, phase one was mobilization. There was an immense amount of fear and uncertainty, but honestly, there was also a lot of unity and enthusiasm to embrace what needed to be done. These were the months when I heard the term the new normal cast about. Phase two was the war. The pandemic dragged on and on. The initial enthusiasm wore off. We all just set our sights on getting through it as fast as we possibly can. Phase three, I hope you would agree, is where we are now, right? And I call this recalibration. When I do board retreats and leadership retreats, which I do almost every single day, I am told specifically, don't talk about COVID. Whether I want to or not, I'm told not to. What everybody wants to talk about is the future, setting strategy, getting ready for the years to come. This is where all of you are. And I base that on day-to-day experience with you as leaders. But let me also say that the window of opportunity will be narrow. Our industry is in a state of immense fluctuation right now. Long-standing utilization patterns, long-standing state and federal regulations, long-standing consumer preferences, all of these have been to some degree or another thrown out of the window. I've been at the advisory board, as Brian noted, for almost 30 years of my career, and I've helped people deal with, you name it, the Clinton plan, the advent of for-profit hospital chains in the industry, the Balanced Budget Act of 1997, the Affordable Care Act. I've worked on it all. But this is the closest, in my experience, that we've ever been to a reset. So if you take one thing away from the conversation that we're having today, let it be this, that it is a pivotal moment in healthcare that will shape the future, and that you as leaders are not passive actors. You have an immense amount of agency in shaping it. In fact, the decisions that you're making today are shaping that industry. Some people I've talked to find that exhilarating. Other people I've talked to find that horrifying, frankly. Everybody in this conference has different levels of risk tolerance, right? I look at my kids. Brian and I were talking about our kids earlier. My daughter is the one in the front row of the roller coaster with her hands up. My son, I honestly don't think that he would get on a roller coaster at gunpoint. Everybody has different levels of risk tolerance, right? I'm guessing, Brian, the world of auditing and accounting is probably not full of huge risk takers, right? But the good news is, no matter where you are in that spectrum, I think we can base our decision-making on some major points of inflection. Yes, this is close to a reset in my mind, but I would never argue to you that that's the same thing as a blank slate. There's always history and context in everything that human beings do. So there are 6 inflection points that I'm going to argue today deserve your particular attention as leaders. These are 6 things that will play out in our world in ways that are not simply incrementally different. Look at the list. I would say they will play out in ways that are directionally different. But there's a time-limited window of opportunity to shape them. And I would tell you, if you do not shape them, they will be shaped for you by somebody else. Somebody at a different place in the food chain than you are, a competitor to you down the street or across the region. Somebody will shape these things, whether that's you or someone else. I would also argue the implications of the 6 are huge in and of themselves. Look at the list with me, right? Value-based payment and virtual care and physician alignment. These are massive issues in healthcare. But let me also tell you that I think they have the potential to tip the needle on some of the larger tensions that, frankly, I've been grappling with for all 30 years that I've been at the advisory board. I try to capture 2 of them on this slide. First, my whole career, I have been listening to arguments and seeing strategies that show a tension between integration and fragmentation? Is the future of our industry one in which a tiny number of players will have a massive reach? I talk to futurists and strategists all the time in this industry who tell me that in 10 years we'll have 30 or maybe 40 health systems left in the United States. That's it. That'll be it. They will have bought up and conglomerated every other organization in the country. We will have giant health systems battling mano a mano with giant health plans and giant pharmaceutical companies, all for the future of who gets what cut of the healthcare dollar. I talked to other futurists and strategists, by the way, equally brilliant, who tell me the exact opposite, which is no. Our future is a focused factory future in which we have a huge number of players, but they each dive incredibly deep on their slice of the pie, right? This chronic disease, that specialty area, this genetic treatment. And the other one, I wonder how you see it. And the other one is the tension that I've always dealt with in my work between consumer sovereignty and consumer management. When is this magic moment going to come that we all keep hearing about, when the American healthcare consumer, gripping their high deductible health plan in one hand and their price transparency data in the other, rises up, to start controlling their own destiny in the healthcare ecosystem and shopping? Let me pause on that for a minute. I'm a healthcare economist with a $4,000 deductible, and I don't shop for my care. Let's just pause on that for a second. If an economist with a $4,000 deductible is not shopping, who the hell is shopping in this world? Right? Or is somebody else always going to pull the strings for me? My physician, my employer. I'm not saying that's good and evil. Those are just different systems. One's not better than another. They're just different. As we have this conversation today, you're going to notice when we pick out these different inflection points that they move the needle here as well on these deeper currents that face our industry. One of the reasons we expect so much change in the next 2 years is that the pandemic has already had, in my opinion, one very real impact, which is it has greatly shifted the dynamics of power and influence in this industry. Pick up the Wall Street Journal today, or the New York Times, or the trade press. Pick up Modern Healthcare. You're not really going to see this. If you scan the headlines on the surface, things look relatively stable. In fact, I would say, given the pandemic, shockingly stable. The prevailing wisdom in this industry is that, okay, we didn't emerge from this terrible pandemic unscathed, but it's not been the disaster that so many of us feared it would be last March and April. I think that's true, and I think that's good. I would also warn you that it is a vast and dangerous oversimplification, because beneath this calm surface, and I'll show you this, I don't expect you to simply buy it, I'll show it to you, that beneath this calm exterior, if you dive down, there's an immense amount of disequilibrium and cracks in the foundation. And any time in human history, when you have certain players with a significantly better position than others, it sets up the potential for significant change. And that's where I'm going to go now. I'll spend our time together in basically two parts. One, I'll go just sector by sector. We'll probably run quicker on some sectors than others, but I'll just give you very quickly a view of what this looks like. How are things going? What is the outlook for the different parts of our industry? What I'm going to show you is what we ran into in this survey, which is surface calm and huge cracks and disequilibriums beneath the surface. And then we'll finish up, depending on how much time we have, just going through the 6 inflection points, right? Because we set up the potential for change. And then what does the change look like? That's part 2. How will it manifest itself across the industry? What does that look like for the different people in this conversation? All right. Brian, we want to ask the first survey question of our audience. Take it away.
Yeah, perfect. Thanks, Ford. So, as Ford noted, our first question relates to, what sector is in the best position today, perhaps to deal with, some of those cracks in the foundation, the iceberg below the surface. Is it health systems and hospitals, physicians, health plans, pharma, health tech? just click a radio button next to your answer and push submit. I believe you have to push submit. And we'll make sure that you get the CPE credit that you so crave.
Who's in the best spot right now? However you define that, financially, politically, strategically, who's in the catbird seat after a year and a half of this pandemic?
And it'll be interesting to see, Ford, what our audience thinks about who's in the best position, and maybe also conversely, who's in the worst position, the most vulnerable position.
We had that question, Brian, but we had to cut it because we had too many.
It's on the edit room floor. We have about 84% of the attendees. I'm going to give it just a couple more seconds here, a few moments to get your answers in, and let's take a look at our results. So I guess unsurprisingly, it's health tech leading forward, but we've got constituents across the spectrum that think that they're in the best position today.
It's fascinating, Brian, because I've done this survey with multiple audiences, and this is different. I mean, I've never seen this many votes for hospitals and health systems, frankly. And I'm going to talk about them first, and you'll see why. You'll see why they're getting some votes, but you'll see also why they're not getting a lot. Usually physician organizations get better votes than hospitals. I'll also tell you that. Health plans is understandable, and we'll go through that. They had a fantastic financial year. And then pharma as well. I think health tech always gets the most votes, and I think that's appropriate because they are attracting the most financing right now. So if you measure this by ability to attract venture money, clearly health tech is a home run. So these are great results, but also I would tell you different, notably different than what I've seen in other conversations. Let's try to build some thinking around the different numbers. Let's begin our tour with hospitals and health systems. This was the sector obviously on the front lines of the pandemic. And if you follow the headlines, which is something I have to do every day in my work, I got to tell you, you have to believe one of two truths. Either hospitals and health systems are the frontline heroes of this terrible pandemic. They have been on the brink of financial disaster, and they're worthy of our sympathy, our admiration, and our financial help. Or the opposite. They've been crying wolf. They've never done better. They're printing money, and those CARES Act checks went right into the bank. In one day of reading newspapers, I will read both of these stories over and over again. At least part of the reason for the bizarrely conflicting narratives became clear to me when we generated this work. This is the spread between the 25th and the 75th percentile of health system operating margin. So it shows you essentially the sort of top line and also the worst performers from an operating margin perspective in the industry. One thing I want you to notice if you look toward the left-hand side is that this range is usually remarkably consistent. Other people in other industries always stare at healthcare and scratch their heads at this, right? You're just not that different from each other. Of course, if you talk to a hospital, the difference between a 6% margin and a 1.5% margin is essentially, life and death. Now, as you might expect, if you get toward the right-hand side, performance collapsed in the first quarter of last year. The pandemic hit, the lockdown was imposed, and their volumes evaporated. But it's after that in the data when things got interesting. Look at the very far right. On average, performance improved as volumes came back and governmental support kicked in. But the variability in performance, by historic standards, was staggering. And we're seeing the same thing in the most recent numbers that we've gotten for 2021. My point is that weird conflicting news story is the news story. Some systems are doing better than they've ever done historically. Others are scratching away day to day for their very survival. What this sets up, if you think about it, is a huge amount of disequilibrium. Systems that have always had variances in performance now have massive variation in performance. what sets some up to win in the market and others to struggle. That's what I want you to think about in terms of the disequilibrium. There was another theme that jumped out at us in our research and in our analyses this year, and that was scale. We surveyed our membership, which, is huge, largest on the provider side, and the health systems, the larger health systems, were much more likely to say that they felt that they had fully recovered from COVID. Now, I want to be careful, and I want to be clear. I am not standing before you today, or I guess sitting before you, Brian, and telling you that I have data that says that scale in the provider industry is determinative, meaning anybody who's big does well, anybody who's small does poorly. It's a one-to-one, end of story. That's ridiculous. Everybody in this conference knows examples off the top of their head of massive national health systems who are doing terribly. I bet everybody off the top of their head can name a community hospital standalone that is doing great right now. So my point is more modest. On average, it's not determinative, but on average, size was an advantage. I think some of this comes down to external factors like government funding and too big to fail. But you know what else? I've heard from many of the people I work with that they made huge gains in the last year and a half in their ability to act like systems. A lot of health systems, as you know, are essentially holding companies. They're collections of assets that largely behave independently. They compete with each other. Everybody wants orthopedic surgery. Everybody wants CABG. Everybody wants cardiac surgery, right? They're collections of assets. But that said, what we've seen in the pandemic is a lot of these holding companies have become much more like operating companies. I guess a crisis tends to focus the mind, and it tends to focus the leadership. Probably not a surprise to you then that we've seen a huge uptick in mergers and acquisitions. I know a lot of this was just pent-up demand. We had a year of almost no activity at all because of COVID. But it's probably also not surprising given everything we've talked about, right? We have a widening gap between the best and the worst performers. We have systems that have newfound power in the marketplace. And we have a huge resurgence of interest in the very idea of building an operating company. So mergers and acquisitions right at the epicenter of that. Well, let me tell you, we're going to get a big test of exactly how system-like these organizations have become in the months and years, because we have a long-term and a short-term significant cost challenge for hospitals and health systems. I think you all know what the long-term challenge is, which is just more and more reimbursement coming from Medicare and Medicaid. It reminds me of the old joke we used to tell in econ class, which is if you want single payer in healthcare, you don't have to vote for Bernie Sanders. You just have to wait 10 years because everybody will be in Medicare and Medicaid, right? We'll get the single payer one way or the other. That's a big financial challenge to the providers in this conversation because, of course, their fixed cost model is based on an immense amount of commercial reimbursement that cross-subsidizes the government. The shorter-term cost problem, I put at the top of the slide, which is a giant jump, 14 or 15% jump in total expense per adjusted discharge during 2020. But, COVID was complex care, a lot of systemic failure cases that, that expense per adjusted discharge went up notably. The problem is at the bottom of the slide, most of the usual cost control suspects are right now, at least to me, a big question mark. I've heard lots of system CEOs tell me they're going to take a hard look at supplies and purchase services. But then I talk to the VP of supply chain. What do they say? Well, all they talk to me about is pandemic proofing the supply chain. That they need to look at upstream at how much political risk there is, and they need to buy less from China. They need to do more domestic sourcing and stockpile certain things for the next crisis. I'm not quibbling, right or wrong. I'm just telling you, it doesn't sound like a formula to me for hardcore cost reduction. In the middle, most of the big systems that I work with right now, capital expenditures are not going down. They're going up. They're spending an immense amount of money on tech, in particular some of the virtual technologies. And also they're trying to build out their ambulatory network and their outpatient network because that's where so much of the growth is. And then there's labor. And that's the big one, as you know. both in terms of the expense, but also in terms of the question marks. It is easy to get bogged down, as you know, in semantics when we talk about the crisis in the healthcare workforce right now. Some labor experts I talk to tell me the problem is clearly burnout. These people were burned out before COVID, and it's just gotten worse. Other labor experts I interview tell me, no, it's just the last year and a half. We have PTSD, it's trauma in the labor force. Other experts tell me it's not those two things. The worst thing is a lack of resiliency in the younger workforce. These aren't the baby boomers. They're not hardy like that workforce. Look, I don't want to split hairs on terminology with you. Let's just agree all of the above. The whole workforce does have longstanding symptoms of burnout. There has been an immense amount of trauma from the last year. And if you look at surveys, the newer workforce does have resiliency issues as compared to the older workforce that we employ. The good news is there are lots of ways to address these issues, right? Most of them take, unfortunately, though, an immense amount of time and money. So we're going to talk about a lot of wonderful things that health systems want to do in this conversation, but all of those will have to be pressure tested against an overburdened workforce that clearly has change fatigue. So this is going to require us to prioritize, slow down, even pause some of the most important things that we would like to do. Just to double click on one obvious crisis that we're facing right now, which is a critical shortage in many markets of nurses. We're seeing just eye-popping signing bonuses right now. We're seeing a lot of bedside nurses voice interest in leaving the bedside to pursue an advanced practice role. A huge number of nurses have simply left the workforce in the last year and a half. The problem is particularly acute in a lot of the markets that I study. I won't walk you through all of the work we have on this. If you're a member of the advisory board, we do tons of research on this issue right now because this is one of the critical challenges that is facing leaders right now. So that just gives you a taste, right? What do you see? What I see is an industry where you have reports, of basically surface stability. It looks like everybody's kind of getting back on track and overall performance is going back to some stable norms. But when you scratch the surface, when you look beneath, you see an immense amount of disequilibrium, differences in performance, right? And challenges. Let's go to the doctors. You remember the headlines from last year. There was a huge fear. It was a national fear. It was shared by so many experts that I talked to that we were going to see a fire sale of independent practice in the United States. And I'm sure you know the reasons, Brian, you know it for sure, which is what is the financial model of most physician organizations? They don't keep any cash. They don't have a cash cushion. They pay everything out as compensation, most of them, big and small. So the fear was, when I talked to any of them in the last year, it was like, if we have to board ourselves up for a month or two in a lockdown, we're not going to be able to keep the lights on. We're not going to be able to make payroll, right? We don't have any cushion. They don't have days of cash on hand. I was saying to people last year, I thought that this concern was overblown. And now we have some numbers for 2020. Look at the upper left-hand corner. Physician income, ultimately across the whole year, held relatively steady. Once again, though, what's the real story? It's when you go beneath the surface that you begin to see the cracks in the foundation. 13% of physicians had a significant period of no money at all. The primary care workforce is estimated to have lost out on something like $5 billion in revenue. Overall, if you measure it purely by the financials, I will tell you that physician groups that I work with definitely did slightly better than hospitals on average. Right? I don't mean to be hard-hearted. There are exceptions to that. But when I talk to physician organizations, the first thing they bring up with me is usually not the issue of financial sustainability. It is the issue of workforce sustainability. That burnout that we talked about 2 slides ago has physicians in a really, really weird place right now. Look at the survey data on the left-hand side. There's still a small number of physicians who are saying, literally, they're just going to up and quit. They're just going to leave medicine. I always scratch my head at that number. I'm like, where are you going to go? You're a doctor. Are you going to go work for SpaceX? I never quite know. They never do leave, by the way. The more frightening number to me is the one in the middle, which is 11% of physicians who are at least talking about early retirement. 25% of the primary care physician workforce is over the age of 65 now, 25% of it. That's not early retirement. That's just good old-fashioned retirement, right? And then you have another 11% of doctors, that's not just primary care, that's across the board, who are at least kind of contemplating, you know what, I think I'm done. I think I'm finished. And then above that is probably the most startling number, 27%. That's the number, by the way, in most surveys. If you look at years ago, that it hovers around 11 or 12. So it's more than doubled in COVID. 27% of physicians are at least expressing openness to the idea of switching their employer. So just step back from this slide for a second and see if you see what I'm seeing. We're heading toward a future in which we're going to see at least a small dip in physician supply, growing competition for the remaining, in many cases, shortage of talent, and an unprecedented number of physicians who are at least saying, you know what, I've got my finger up in the air. I'm wondering if I want to change my employment model, right? If that's not a recipe for disruption, I honestly don't know what is. It doesn't mean it's a guarantee, but I hope you would agree it's at least a formula for aggressive change. And I want to come back to this issue a little bit later on. For the moment, though, let's turn our attention to another sector which has had a very different experience in the last year, the health plan. So we were being overwhelmed, as you know, last year with these terrifying stories about, mass fire sales of physician practices and hospitals on the verge of closure. We were also being inundated with headlines suggesting that health plans were having the opposite experience. They weren't just surviving. They were like having the best year of their corporate lives. And again, there's a lot of truth to it, right? It's a pretty simple math. You collect a lot in premiums. If you're not spending as much on care because of the lockdown and the, deferrals, you do pretty well financially. Here too, though, I will tell you that's true. But here too, the argument got more complicated the deeper we got. What you see here is an analysis of enrollment trends broken out by the kind of plan. So I put the big nationals at the top. I put the state-based blues in the middle. And then we put the regionals, the bigger regionals. We limited it to people with 100,000 enrollees or more at the bottom. What do you see? The big thing that jumped out at me when we measured it this way is look how much better the nationals are doing at capturing Medicaid risk and Medicare Advantage. Some of this will smooth out as the economy recovers and Medicaid enrollment decreases and commercial enrollment does better. But look at the Medicare Advantage piece, right? I think that's particularly important. There's no reason to believe that that's temporary. That's not economic. That's demographic. It just puts the big national plans in a significantly better strategic position than, for example, the blues. And this is a conversation I have all the time with the C-suite of the different blues around the country. I do a lot of those talks. And I got to tell you, they bring it up themselves every single time. They feel they're behind the curve on Medicaid and Medicare Advantage in particular. And those big nationals at the top, they're not exactly sitting on that cash. They have been using that money to double down on mergers and acquisitions. And look at my list here. These are not reactive deals being made from a position of weakness and fear. These are aggressive, confident moves along long-standing strategic ambitions, buying up physician practices, particularly primary care, capitalizing on the shift to home, deepening their foothold that already exists in the specialty pharmacy space, and so forth. So we see a lot of movement here in terms of the big nationals. Again, this is what I mean by disequilibrium. They're not just taking the money and sitting on it. They're using their strategic advantage, they're putting it to good use in terms of moves, horizontal and vertical integration. All right, there was one exception to my story of surface calm with disequilibrium beneath the surface, and that was the pharma and device sector. There was some early divergence in COVID, but generally this side of the industry has reverted back more or less to pre-pandemic norms. Again, there was an initial dip of finances that recovered, and they've been tracking with the rest of the economy. Now, the rest of the economy also has issues, right? Particularly supply chain issues. And when I talk to pharmaceutical companies, and especially device companies, this is what they want to talk about. They want to talk about all of the disruptions and the inflation in the supply chain. Another one of the downsides is the political scrutiny has come back full bore as well, particularly, I think, for pharma. I will admit to a lot of surprise. I really did think pharma would get more of a halo effect from their rather miraculous vaccine development than they got. You don't see much of a halo effect in VC these days. That does not mean that the pandemic has had zero impact in life sciences. There are clearly some structural changes that have happened and are arguably here to stay, and that will have spillover impact as well. Just to call out one that comes up frequently in my talks with pharma is the decentralization of clinical trials. They will tell you that generally these are quicker, easier, and cheaper than traditional clinical trials. It allows them to conduct trials on far more diverse groups of Americans. That is not always happily greeted by some of the payers I work with. The lack of trial diversity historically is also a negotiating lever on price. Because if you're worried that the drug is going to interact differently with different groups, you may have to hold the price down as a result. It's also a challenge for the academic medical centers that I work with, who traditionally have cornered the market when it comes to clinical trials. But it doesn't shift the dynamics of power and influence in the pharmaceutical or device industry significantly, that, saying this is up and this is down. But if I had to name one clear winner from the last year and a half, I think we can agree, and I saw this in your survey, remember, Brian, that would be tech, health tech. Digital health specifically, and I don't see any sign of this slowing down soon. Digital health, to your survey response, attracted more funding in the first half of 2021 than in the entirety of 2020, already in the first half. And by the way, look at 2020. That wasn't a bad year. That was a record year for venture capital funding of digital health, and we have already superseded it in the first half. I thought you might find it interesting, not just the eye-popping dollar figures, but also what people are investing in. So look at the bottom of my slide. It's a little bit of a confusing graphic, but on the left is 2015, and then we move over to today, or nearly on the right. What you see here, I put, are the top 3 areas within digital health that attracted venture capital funding in order. What I want you to notice is, if you look back toward 2015, 6 and 7 years ago, it was really about, sort of fitness and wellness, some of the general IT areas, workflow, productivity tools. What you see as you move toward the right is more and more emphasis all the time on digitizing, making virtual the actual delivery of clinical care itself. So this was happening even before COVID, is my point. But COVID obviously has been a giant accelerator to that trend. I do want to go a little bit deeper on virtual care in a bit. I hope you're seeing, again, what I saw, and not because I wanted to see it, but because it was what was in the data, which is there's this surface stability that, again, masks critical divergence in performance below. It wasn't true everywhere, and pharma and device, I think, was a notable exception. But it was true in most sectors. That's always important to identify disequilibrium. But I would argue to you it's a potential game changer in a time of great fluctuation. Because when things are in flux, those in a position of strength, that you look historically, always have an outsized opportunity to shape the future. All right, let's talk about the other side of the coin. I know we have a lot, Brian, of commercial payers on the call today. So let's talk about their perspective and then do a little bit of time quickly on Medicare and Medicaid as well. When we talk to companies, to American employers, the commercial payers of the world, health benefits was actually a bright spot in 2020. Over a third of American companies saw their healthcare costs come in at least 8% or more below budget. That's great, right? That's similar to the good performance of the health plans. You collect, you have a lot of money budgeted to spend on healthcare and you don't spend it. So they did much better in the budget in 2020. Now, look at 2021. Spending is projected to go back up this year. But I don't hear from most employers. I do a lot of the big employer conferences and benefit managers and so forth. And I don't hear from them a huge amount of concern about 2021. It's back up, but it's kind of in line historically. The big concern that they frequently express to me is 2022. A lot of fear about 2022. They'll tell me that, all this deferred care, We've had all of these later stage diagnosed cancers. Nobody got their colonoscopies. Nobody had their moles checked in the last year and a half. We have all of this burgeoning, all these behavioral issues that have popped up and worsened during COVID. There's this feeling among employers and benefit managers that I talk to that, this is kind of rolling up into this sort of, tsunami of utilization that we're going to see in 2022. I don't have a lot of data that would indicate, that we should be battening down the hatches. A lot of the data just shows you sort of a continuation of what we've been seeing in the last few years. But I don't mean to downplay the fear. It is ever present in my conversations with employers. The balancing act for employers, as we all know, because we are all in this conversation are employers, is maximizing your savings on the one hand and, keeping the workforce and the family members happy on the other. Now, normally I get a little skeptical of the latter because, I have a $4,000 deductible. I'm guessing, Brian, I've lost out on that equation a few times. But I got to tell you, I am not discounting the importance of employee satisfaction right now. The American workforce is in a really odd place in this peri-pandemic, movement. My point to you is, something like 40% of American workers have said that they have thought about leaving their job. So my point is, any additional cost shifting to the workforce is an increasingly tough sell. I've been telling providers for a while that we're seeing hints, especially in some states, upper Midwest, for example, of a plateau in the high deductible strategy, that we're seeing a lot of people sort of feel they've exhausted that run. It's not true everywhere, but it's true in the states with the highest deductibles. So I think when you have the workforce in this volatile situation, that only adds pressure to avoid those strategies. So here we have a conundrum, right? We have employers telling me that they're scared of a huge utilization spike, a spike in spending starting in 2022. But the mainstay strategy they've used to reduce spending, high deductible health plans, seems to be, waning in the marketplace. What they tell me they're going to do instead in most of these conversations, I put it at the top of this slide on either side, are generally different forms of steerage. Steerage is the word I want you to remember. Again, I've been doing a lot of these employer talks, and they always bring these strategies up with me. They always ask me about who's doing what. Centers of excellence contracting, high value or advanced primary care networks, contracting with primary care separate from the rest of the health system as a leverage point, virtual navigation services, concierge navigators. By the way, I have a concierge navigator. I didn't even know I did. I was looking for an orthopedic surgeon for my bad back, and my phone rang, and it was my concierge navigator. I was surprised. I'm like, I didn't know I had you. And then he was trying to help me. He's like, I'm going to help you find this, orthopedic and neurosurgery care that you're looking for. I quickly realized he was trying to help me find the cheapest orthopedic surgeon. It's like, it's weird because when I have a concierge at the hotel, they help me find expensive things, but you seem bent on helping me find something cheap. Anyway, you get how these things work, right? These strategies will become only more important, I think, as employment levels pick back up, hopefully, knock on wood, with a recovering economy, inflation be damned. Because the other factor that has protected the employer budgets in the last year and a half has been the decline in the size of the workforce. I've been looking for these numbers for a long time. They've been very hard to get during COVID, but they are staggering. Commercial coverage dropped by 14 million people last year. 8% of the commercial market disappeared last year. Now, if you wonder why those conversations with the C-suite of the Blues that I have are sort of, harsh conversations, this is why. This is the mainstay of their business. This is also probably the first real test of the Affordable Care Act insurance safety net. And I don't say this politically. I never take sides politically. But it does appear to have mostly worked. What I mean by that is look at the bottom of the slide on the left. We had this terrible global pandemic, and the uninsured rate in the country only went up around 1%. That's rather remarkable. Some of the offset came from the Obamacare exchanges, which, as you know, Biden has been spending some money on. But most of the growth, as you know, came from Medicaid across the country. Medicaid today is bigger than it's ever been before. Managed Medicaid HMOs, they grew by nearly 20% themselves in the last year and a half. which makes it even more remarkable that we're not seeing big changes to Medicaid rates right now. That's partly because tax revenues ended up looking much better than expected. States that were hit hardest, I put in red on the graphic. These are the states that lost the most of their tax base. What do they have in common? Can you see that? No offense to North Dakota and Oregon, but with those two exceptions, what you're looking at are mostly tourist states. So Florida, Texas, Hawaii, Alaska, Nevada with Vegas. These are some of the biggest tourist economies in the country. And it was a really, really bad year for tourism. As we all know, that was probably the sector most damaged in COVID. What you see as you get to the lighter shaded states, look at Idaho did best, by the way, by far. I don't know what Idaho did to hold on to that, but their tax base massively increased. I'm guessing it's all those Californians, Brian, who keep moving there. But again, this shows you, by the way, how many states could you get reduced Medicaid rates? Six states. Let me just give you a point of comparison. I forget the exact number, but in 2010, 2009, coming out of the Great Recession, that number was something like 47 states. That's how damaging to the tax base the Great Recession was, right? So what you see is a very different crisis. The big questions for Medicaid are what happens largely when the public health emergency ends. One of the things people don't really talk about is that states can't disenroll anybody from Medicaid during a public health emergency. Now, Team Biden just extended that through January. There is some talk in D.C. of extending it all the way through 2022. But someday in the future, the president will stand before us and declare the public health emergency over. And then I think you will see much more volatility in the Medicaid enrollment rates than we see now. You're probably also wondering if the federal government will come to the rescue. There are certain things that they could do, but let me just mention, I think the big issue here is the federal government has its own problems. Headlined, as you can see here, by the Medicare Trust Fund insolvency reports. I know what you're thinking, and I hear you. This report comes out every single year. The Congressional Budget Office does one, and the Medicare trustees do another. They sometimes, they often contradict each other, which they just did. The Congressional Budget Office insolvency report was notably more pessimistic than the Medicare trustees. But this comes out every single year, followed by an inevitable sort of Chicken Little sky is falling media round. To be honest with you, I almost always ignore this. I don't spend any time on it at all because the insolvency is like usually 13 or 12 years away, which is 1 million years in politics, right? But that's not what we're talking about right now. If you use the Congressional Budget Office numbers, this is literally as close to insolvency as we've ever been in the history of the program since 1965. And every time we've gotten even remotely close to this in the past, as you know, Congress has jumped in with both feet. It's how we got the Balanced Budget Act of 1997, which I mentioned earlier. It's, by the way, part of the reason we got the Affordable Care Act. Nobody ever seems to remember this, but a huge part of the Obama-McCain election battle was over this, would-be insolvency of the Medicare Trust Fund and what they were going to do about it. Nobody ever remembers that, but that was a big part of the Affordable Care Act. There are lots of feasible strategies that Congress could pursue to build up the trust fund. I listed the big ones on the slide for you. At the top, this would be the best one. They could wait for tax revenues to recover with the economy, or they could make some bets on some of the value-based care strategies that have bipartisan support. There are many of them. What's the problem with that? The problem with that at the top is it's incredibly slow. There's no guarantee they would produce the necessary revenue in the necessary time frame. There are some faster strategies in the middle that Congress could consider, but talk about taking the wolf by the ears. You could jack up Medicare premiums, or you could cut Medicare benefits significantly. I don't know, Brian. What percentage of people over the age of 65 vote? I think it's like 152%, right? They vote twice. So I don't think they're going to do that. So the most likely strategies are at the bottom because they're both fast-acting and they're a little bit more politically palatable than angering the elderly. Cuts to drug companies, cuts to hospitals and health systems, or cuts to Medicare Advantage health plans. As you know, there's been a lot of debate about drug prices in D.C. in the last few weeks. It does appear, it was going to be in the reconciliation bill, and it was out. Now they're trying to put some of it back in, but it's a watered-down version, even if it is back in. And remember, even if they saved money that way, Congress would have to specifically then allocate in a future bill that money for the Medicare Trust Fund. And I think we've seen there are lots of things that they want to spend money on right now. So I'm not putting my money on cuts to pharma as the salvation for the trust fund, which means we're probably shaping up for a showdown between hospitals and Medicare Advantage health plans. Hospitals are the perennial target. We were the target. They were the target in 1997. But I will tell you, there's a lot of momentum in D.C. right now talking about Medicare Advantage plans, how much money they make, their risk adjustment formulas, their star ratings, and so forth. So we should probably prepare for at least something there as well. All right. The last thing I want to talk about, we have another survey, which I'm going to ask Brian to take over, is we want to look at the volume numbers and the utilization expectations. So before I get into it, let's do a pressure test of the audience and get those credits for you. And I have to do a couple more here before we run out of time in half an hour. So Brian, take it away.
You got it. Thanks, Ford. So you mentioned earlier the underlying fear, perhaps, that there's a big surge in utilization down the road. Participants and audience, tell us, how do you think the pandemic will impact overall utilization across the next 2 or 3 years? We see a modest increase, a larger increase, no change, modest decrease, or larger decrease. You can see the lettered answers there on your screen. Again, as a reminder, click the button next to the answer you select and then hit submit. If you can't see the submit button, enlarge your slide view. It might be hiding underneath that. So we've got about 2/3 of you that have responded. As Ford mentioned, we've got a lot of content to get through and CPE questions. So we're going to move relatively quickly. So those that are swearing that they're not on their phones right now, just make sure that you click a button here so we can get you CPE. And Ford, let's take a look at the results here.
Yeah, we're above 80%, Brian. Interesting. Now, this is very much in line, Brian, with what I've been seeing. It's probably a little bit more bullish on the top end, which I like, in terms of a greater than 5% increase. Every time I've done this survey, though, B has been the most popular answer. And then there's always a little bit for the either steady state or kind of a 1 to 5% decrease as well. So this is very, very consistent. Again, slightly more bullish on that first one than I've seen, but pretty consistent. My guess is we have some of the payers up there that are worried about that spike in utilization in 2022. But generally, most folks I've talked to are voting for B. Let me give you our prediction at the advisory board. We do a 5-year growth projection every single year. We update it every year, just based on politics, economics, demographics, technology, all the different factors that we look at. You can see it here changing from 2020, which is a lighter shaded bar, to 2021 next to it, which is the darker shaded bar. What you're looking at was what we've been looking at for years in terms of the market, which is a slight contraction on the inpatient side. So you can see that's intensified a little bit with COVID. We've gone from around a 2% to around a 3% contraction expectation on the inpatient side in the next 5 years, more than compensated for, by the way, on the bottom left by significant double-digit 12, 13% growth on the outpatient side. So what you're seeing here in our projections is a slight intensification, but nothing radical, right? Nothing different than if you would have been following the industry projections. This is nothing hugely different than what you've seen, which is most people expect some contraction on the inpatient side and a lot of growth on the outpatient side. This is not the story. Once again, you got to go below the surface to get to the real story, and it's here, which are the service lines. If you look at the service line level, that's where you see the significant shifts. Notice, again, it's all over the place. Some things are up, some things are down. It's why at the aggregate level, you don't see that much changing. At the aggregate level, it's all kind of a wash. But nobody would tell you on this conversation that these are insignificant numbers, because these are changes, positive or negative, to some of the health system's biggest profit centers or cost centers. Health systems in this conversation, as you know, live and die largely at the service line level, not at the aggregate level. So you notice we expect a bunch of changes, particularly in the early years. The farther you get from the most acute phase of COVID, the smaller the impact tends to be. But let me just note one thing that we believe is probably here to stay, which is a shift not in how much care people need, but in where they get it. A massive ongoing site of care shift, which is one of the things I know we're talking about in our conference. That the clearest leading indicator of this to me right now are ED volumes. Most volumes have come back pretty well. A lot of EDs that I work with continue to lag. But I don't think it's an ED problem. It's a site of care shift. This is the canary in the coal mine for things moving elsewhere. By the way, you can argue that those are good things to move, right? That this is not acute care. This is not emergency care. This shouldn't happen in the ED. But it certainly captures for you how much of the care has shifted. Again, what you see here, even on the payer side, I think it's the same story, right? So Medicaid has been the safety net. We don't see a lot of changes on the horizon. We don't see many cuts to Medicaid reimbursement. But the public health emergency will end sometime in the future, and then you'll see much more turbulence. On the Medicare front, nice prices. They've been giving us, it's below inflation, but they've been giving us reasonable price increases compared to historically. But the trust fund is running out of money. And we think sometime after the midterm elections, there's going to have to be something far more radical that goes on by one side or the other, whoever's running Congress. And then on the commercial side, again, the last couple of years have been steady state. With the decrease in the job ranks, they've done okay in terms of, and the decrease in utilization on the budget. But all of them, as I told you, are worried about 2022. All right, let's shift our thinking here. We only have a little bit less than a half an hour. So let's shift our thinking into the 6 inflection points. I put the 6 here again, and then I want to stop again, Brian, and do a quick survey. Which of the 6, so look at them here: price transparency, value-based payment, physician alignment, virtual care, home-based care, health equity. Which of the 6 is, as a leader, your highest priority? Take it away, Brian.
Thanks, Ford. Yeah, click the answer to the question, which of these is the highest priority today, and hit the submit button. Just a reminder, typing your answer into the Q&A box doesn't work. You got to hit the radio button next to your answer and hit submit. We have, this is, I believe, our 3rd polling question. And we have 3 more to go. Again, as a reminder, you've got to get 5 of 6 to qualify for CPE credit.
That's on me, Brian. Make sure I get to them.
Yep, we'll get through it and get you the credit you deserve. We're going to wait just a moment here, get you above 80, and we'll see what our audience thinks about these priorities. Interesting. Yeah.
That tells you a lot. I mean, it also talks about the audience, right? This is the first time in this survey, Brian, that I've not seen physician alignment get the most votes. That's partly because I spend a lot of time with providers, right? And that's always their number one issue, or almost always. Value-based payment shows you we have a lot more payers, right? And a lot more folks sort of across the care continuum in the conversation. Also, a lot of votes for price transparency. Which is very interesting. Less so for home-based care, as we can see, which is also, there's a lot of feeling that that's kind of a passing fancy. But let's address that as we go. All right, just quickly on price transparency. As you can see here, this is not the first time we've talked about price transparency. In fact, we've been talking about it for about a decade. That's almost been a hot topic. I will also tell you, honest moment, I don't think we've seen a lot of meaningful change in price transparency as a result of price transparency in the last decade. But it's also fair to note, and you saw that in your votes, that this is a new era. The federal government has absolutely doubled down. In the final months of the Trump presidency, we got a slew of new transparency regulations This is also, though, a bipartisan issue. I know Biden has walked back so many things that Trump did, but this is not an area where we expect that. Most people I talk to, we have people from across the spectrum at Moss Adams today. So, I assume you're aware probably of the stuff that directly impacts your business, but very few people that I talk to realize the full picture. We have new hospital requirements that are going to affect this year. We have new surprise billing regulations, many of them. And of course, the health plans on this conference, you will get your regulations next year. So just pause. It is fair to say that we are about to see an unprecedented level of pricing information that will hit the American market. Now, this generally, in my conversations, pushes the conversation right to the issue of consumerism. Is this finally that moment that the American healthcare consumer is going to be armed with enough relevant data that they can truly begin to shop, not just for, little things, right? Urgy centers and so forth, but, across the board, procedures and long-term treatment. The sector I will tell you that I'm going to watch most closely is at the bottom of the slide, and those are the employers on this conference today. When I talk to people at a cocktail party about price transparency in healthcare, it doesn't get a lot of play. When I talk to employers about it, they are hungry for that transparency. When I do those employer conferences, one of the first things they always bring up with me is that RAND study that came out in 2019. It's weird. They can almost all quote it verbatim. What that shows you is, A, they're massively cross-subsidizing the government. The procedural cross-subsidy is like 250% now. And also, they will tell you that large health systems charge them notably more money than smaller health systems. So that's an already charged situation, and then you would kind of supercharge it by dumping all of this pricing data right into the tooth and claw of it. You would also imagine a bunch of people in the Silicon Valley, a bunch of tech companies will take all of this data, right, and try to make it into, sort of off-the-shelf solutions for employers that don't have the time or the expertise to shift through it on their own. So I'm just giving you one scenario, which is classic economics. Adam Smith is smiling in his grave, which is you dump a bunch of price information on the market, people compete on the basis of price, and price goes down. That's what the government has always wanted from price transparency, and it's based on classic economic theory. I will tell you, if you look at the history of price transparency, there is another scenario here, and that is that they dump all of this price data on the marketplace that is ignored by consumers, ignored by you as employers, but very much listened to by both health systems and insurance companies. But that scenario is as likely to result in a price consolidation as it would be a decline in price. You can imagine it very easily. Small hospitals in a marketplace discover that the giant health system down the road is getting notably better paid than they are, and they start demanding the same treatment. Maybe they get it, maybe they don't, but that would be a force for price consolidation, not price reduction. So much of this, as you also know, depends on, exactly how usable the data is. Does everybody comply to paint the complete picture? Is the information published in a way that is user-friendly and standardized? Is it married with things like wait times and quality in ways that I can shop with? And some of it, of course, will also depend on how much pressure the government puts on it. As I'm sure you know, the Biden administration has proposed that the penalty for a large hospital that does not comply would top out. It tops out right now at around $100,000, that it would top out instead at about $2 million. It's not been finalized, but you get a feel here. They're trying to kind of up the pressure in terms of compliance. So let me give you the scenarios quickly. You can see here, scenario one, nothing happens at all. We go through this exercise one more time. We release a huge amount of data onto the marketplace. People don't find it relevant. They don't shop with it, and it goes nowhere. There's nothing to say that that's an unlikely scenario. That is the scenario of the last 10 years. That's what's happened. If we move to the right because of government pressure and or pressure from the employers in this conversation, both of them would have to be applying pressure for real shopping, then you begin to see two scenarios on the right. Either the price information becomes a true market disruptor, classical economics, right? People start to compete on the basis of price. I have community hospitals all the time who tell me this is the world they want. because they're significantly less expensive than their bigger name competitors, and they would love to take market share on the basis of price. Or at the bottom, it simply becomes a price enforcer, at least in the near term, right? It consolidates price, not reducing it. Again, remember my point. You are not a passive actor in this. This is being determined right now. No one knows how this will turn out. And different markets could turn out differently. So my question to you, wherever you're sitting in this conference, is which one of these three scenarios is your preference? And maybe that's scenario number one. There's nothing wrong with that, which is that this goes nowhere once again. But very curious as to if it'd be one of the two or three on the right-hand side. All right, the second issue I wanted to dive deep on is value-based care. There was a real dichotomy in my conversations last March and April at the height of the lockdown. When I was talking to folks on the West Coast, many of whom have capitated payment or risk payment, they were crowing to me about how great capitation and risk payment are because, look, I still get paid per member per month up front, regardless of foot traffic. These poor fee-for-service providers, they're on lockdown. They can't bring in any revenue. I get my check up front. Yet another demonstration of why this is the future of payment. I also talked to folks on the East Coast and in the big fee-for-service marketplaces who said, yeah, I get that, but we're right in the middle of a global pandemic. I'm not going to take more risk financially than I'm already facing every day in my life. Toward the bottom of the slide is the change in attitude that came as the pandemic improved. Everybody chilled out a lot, right? The capitated folk were not as likely to crow to me. The East Coast providers were not as likely to avoid risk. In fact, let me say, the one consistent thing in all of these numbers is a huge jump in the number of organizations that would like to take population risk, right? That never seems to go anywhere but up. In particular, if you look at the last year, all of these organizations that are providers that have a successful health plan, Kaiser, Intermountain, Geisinger, UPMC in Pittsburgh, ProMedica in Toledo, all of these guys did significantly better because of their health plan, because they have successful health plans. So there's only more and more interest in it. Let me ask you, do you think they'll get more? So Brian, let's do another vote on where they see the risk market, value-based care market going.
Yeah, it was interesting, Ford. On the previous question we asked, I was mildly surprised that 30% of our audience thought value-based care was the most significant structural shift there. I'm assuming that means our audience is thinking there'll be more value-based contracting, but it'd be interesting to find out. Again, click the radio button next to the answer that you select and hit submit.
Less value-based contracting, steady state, none at all. Are you seeing signs of increased interest, even if it doesn't come with more contracting, or is there actually more value-based contracting? This is research in the moment for me because it's the question I'm trying to answer for a lot of organizations. Very curious, Brian, as to this one. This I can actually use right into one of my studies.
Right. Well, let's check out the results and see what our audience thinks.
All right, we're above 80. Wow. Now that's interesting. This is an aggressive bunch. I will tell you, historically speaking, when I ask this, Brian, B usually gets the most votes, and we're not even close, which is no change. No reductions, but no change. But we have two things here. One, increased interest, even if it's not paying dividends, but actually significantly more value-based contracting. Now that's fascinating because this is showing you a changing market, and this is exactly what people want, right? So that is truly fascinating and good data for me. What we're finding is the closest proxy we have, by the way, to measure how much risk is happening in the marketplace during COVID is, believe it or not, the ACO program. And I know what you're thinking. That's not capitation. That's a fee-for-service model with an incentive layered in about the cost curve. Also, it's a voluntary program. And CMS actually chose to skip the application cycle last year in COVID. So what you see with that red bar is it looks like a program in decline. That's only because they didn't welcome any new entrants in the last year. So I don't want you to exaggerate that and think that, it's falling apart. It's not, right? But what's more important, I think, is how the federal government is planning to respond. One of the great people at this conference is Liz Fowler. I know is talking later, Brian. And this is, we're seeing a lot of signs from the Biden administration that they are going to be interested in increasing downside risk and even possibly mandatory models in the future. So I think that this is a great way for a lot of the health systems to access risk contracting when they can't get it from commercial payers, for example, or health plans. So again, all eyes are on that in terms of the later presentation. Let's ask. I'll tell you something which we should be watching, which is there more risk in the marketplace? Absolutely. That's not the question. The question is it only going to doctors? Because we saw, even during COVID, increased evidence of risk contracting between health plans and physician groups and physician organizations, even smaller ones in some of these states like North Carolina and Massachusetts. So the tipping point for us, do my scenarios real quickly, is not whether we're going to see more risk or not. Let me answer the question. We are, and your answers in that survey bolster my answer, which is you're seeing it, so I'm believing it even more. So we're going to see more value-based contracting and risk contracting. The question is, who's going to get it? Is it going to be an incentive just for physicians, or is it going to be an incentive for the entire side of the provider organization? I will tell you that health systems I work with, their great fear, it's an existential fear, is that they get relegated to downstream fee-for-service reimbursement, and they're not part of the risk contracting. That's not a scenario they like, because they feel that they're going to be, downstream and in a sort of commodity model that's not part of the incentive that insurance companies and physicians will be sharing. All right. The next thing I wanted to talk about, the next issue, is the issue generally of physicians. And this is a big one. I think the next 5 slides are some of the most important I could share with you today. Remember, this group was a little bit different, Brian, but in most of the conversations I do, physician alignment is the number one issue that they want to talk about. Of all the inflection points that we're going to talk about, this is probably the one with the longest, farthest reaching implications. Let's take stock of where we are right now. As you can see on the left-hand side, more physicians than ever are employed by hospitals and health systems. About a third of the entire medical staff of the United States, way, way higher than that if you look at certain specialties, or like primary care, for example. The numbers are way above, 50%. But I've also seen some things in COVID that indicate that the tide might be turning. So look at the right-hand side. This is a survey of medical residents in their last year of residency. And what we saw is that the interest in taking a hospital job plateaued. I don't want to exaggerate it. It didn't collapse. It just didn't grow. But it's been a long time since that number has done anything but go up. Some of this is long-standing concerns by physicians that, that's stuff they've always complained about, which is if I take a job with the health system, I'm going to lose too much autonomy, or I'm going to lose my entrepreneurial zeal. Let's also agree that, it's stressful to work for a hospital in the front lines of a global pandemic, right? And then I also want you to think back to my last inflection point, which is I hear from physician organizations, they bring this up. I want to be part of the value-based care contract. I want to have this incentive, over time to be more cautious about care. And I'm afraid the hospital's not going to be included in that. So we hear that as well. And to be clear, physicians have no shortage of non-hospital partners to look to these days. Private equity had a record year in fundraising. 2020 was not a record year in terms of deals. Nobody wanted to fly around or shake hands, but man, did they raise some money. There's apparently $1.5 trillion with a T dollars sitting around in what's called dry powder, which is the industry term for money looking for a home. $1.5 trillion looking for a home. Now, not all of that will go to healthcare, but look at the left-hand side in those bar graphs. Healthcare is always in the top 3 when you talk to private equity executives. In terms of actual deal making, most of these deals historically have been focused on orthopedic surgeons, urology, GI, and women's health. Those have been the big 4 in the last 5 years. And what those share in common, Brian, I'm sure you figured out, is they have very large rates of profitable outpatient surgery, which is also part of the model generally in private equity these days. The second player that we're seeing make a lot of moves, I put it in the middle of the slide. I don't have a great term for it. I apologize for my clunky verbiage. Non-traditional independent physician groups. Historically, I've called these startups, which was a nice word. It doesn't really fit them anymore, though. Several of them are huge. A few of them have successfully gone public during the pandemic, and all of them have grown in the last year. In other words, they didn't just survive COVID. They flourished in COVID. And then last but not least, of course, are the health plans. Those big national health plans have done exceptionally well financially, and as I told you, they're using their money to invest in the marketplace, in the provision of care itself. All right. So the question becomes, right, where are the doctors going? Let's see what you've seen. Is this question 5, Brian?
This is question 5. And we've got a follow-up question. Maybe we'll just push that second question up here to make sure we get all the questions in.
Let's do it.
And then we can work through the last section. But have there been notable changes in physician alignment in your market over the past 18 months?
And let's see what that is. Are hospitals acquiring? And this is not, by the way, pick one. This is pick multiple. So anything that applies. Anything that applies, let's see it. Because it could be 3 of these or 4 of these or 2.
And again, acquisitions by local hospitals, defections from local hospitals, new investment from private equity, acquisition by health plans, entrance on non-traditional aggregators that Ford just talked about, or the one or more of the above. And we're getting close to 80%. And those that are participating here, get ready because we're going to have another one coming right up.
You only hit one button. Sorry about that. That's my bad, Brian. I think you can only pick one. So pick the one that's most profound in your mind.
Exactly. And if you want multiple, pick the last one. Let's see what this looks like. And they were ahead, one step ahead of you.
Where I should have said that. I apologize. You're right. Which is, you're seeing multiples. Now, I will tell you, in most places I work, it is a combination of hospital acquisition and then the private equity. So that's health plans are in there too, but this is typical of what I see, which is hospitals continue to employ and then private equity as well. Go ahead and give it. Let's give it.
Amy's anxious to make sure we get our CPE in, so let's just go to the last question and have our audience tell us what is your biggest obstacle in maintaining virtual care market share. And I think this will set us up for the last discussion here. That we're going to have on some of these significant factors is A, reimbursement, B, required investment in technology, C, physician resistance, B, better capitalized competitors, e.g. third-party vendors, or something else. What's your biggest obstacle in maintaining virtual care as we start to talk about one of the significant factors that you had mentioned, the shift potentially, and that's telehealth.
Agreed.
I'll just give you a few more moments for those that want your CPE.
We're getting there.
And we'll take a look and see what we think. Come on, people. Help us out here. Click those buttons.
72, 74. We're almost there, Brian.
74, yeah.
Credit is coming.
Watching the stock market here.
The credit will happen.
And let's take a look at our answers.
All right. Reimbursement, unsurprisingly, right? And also tech. Yeah. Those are helpful to me because reimbursement is always number one, but this is a good one, which is the required investment in technology, because that is a hotly debated issue right now as to where this should live, and a lot of the debate has to do with what people are willing to spend on technology, third-party vendors versus the hospitals and health systems. I'll say a few things about that, and then let me get into. Let me just say a couple of things about virtual care, and then I'll finish up. Then we only have about 4 minutes. So everybody knows what happened in virtual care in the last 18 months, which is we had this huge explosion and lockdown. Some markets went to 80, 85% virtual care in terms of all visits. So this is telehealth as a percentage of total visits on the left-hand side. Nobody thought we would maintain this, and it dropped back down. By early summer, it was already back into 15%. It's hovering now. It's about 11% of all visits are virtual right now. So again, I think that's interesting, and it's been hovering at around that level, 10 to 15% for over a year now, like for 14 months. So that tells you a lot, I think. We didn't go back to zero, but it wasn't exactly a brave new world either. It's like an augmentation of our existing world. Look at the blue line above that. Guess what didn't go back down? Psychiatry. Something like 66 or 67% of all the virtual visits that we're seeing right now in the marketplace are teletherapy. Eating disorders, anxiety, depression, some of the substance abuse issues, a huge range of issues, many of which, as you know, spiked during COVID. So this could be a real revolution in a few areas. I would say psychiatry and diabetes care in particular. Here's a weird question. Look at the right-hand side. Nobody really talks about this, but who delivered all of that virtual care, right? Who delivered it all? It was, wait for it, your own local physician. That didn't get as much attention. Now, if you told me, Brian, a year and a half ago, 2 years ago, there was going to be a revolution in virtual care, and my, bless him, sleepy primary care physician was going to be at the forefront of that revolution, I would have laughed out loud. I would not have believed you, right? But that's what happened, right? The traditional providers, your doctor, your local health system, were essentially handed the winning position in the marketplace. I know we're out of time, but I'll do this one last slide with you, which is where are we going to go in the future with this? And this is the debate that we look at. On the left, on the one hand, you have, is it going to be hospitals and health systems and physicians who hold on to that market share? The pros and cons. The pros are, there's no disruption. It's my local doctor. I like that person. I don't like disruption. The cons are it's fear they won't invest a lot in technology, and that also employers worry that they have a perverse incentive, right? And then on the other side, you have third-party vendors and tech companies. The pros there are they spend a lot on great technology, which probably means better access. The cons are there's a worry that that's just going to be another layer on the whole healthcare system and cost us a fortune without being coordinated. All right, I know I'm out of time. We had a ton to cover. I'm glad we got to all the questions, so you get your credit. It's been an honor. Brian, why don't you take us home?
Ford, thank you so much. Really appreciate it. Appreciate the audience hanging in there with us. I mean, this is thought leadership that you just can't get anywhere else, unless, of course, you're a member of the advisory board, which many of you are. But Ford, we always appreciate you joining us for a great conversation and a table setter for the rest of our conference. I'll just do a bullet point close here since I know we're over time. We did want to highlight for you breaking news here, a special announcement that we have picked a date for an in-person conference next year to get back in. So fingers crossed, knock on wood, early November, back in Las Vegas at the Red Rock Resort. So we look forward to that. Thanks again to Ford and the advisory board for your partnership over the years and the great thoughts here today. And as Ford alluded to a little bit earlier, we have as I'm flipping through slides here randomly, we have a great couple of follow-up sessions here. The first to be a visit on CMMI's future. Ford mentioned Liz Fowler. She'll be joined by Dr. Mark McLennan in a session that will be moderated and really good follow-up discussion on value-based care. And then finally, behavioral health transformation and payment reform panel. So you'll receive some information and follow-up webcast. Very important, the survey that we have in there. We really want you to participate in that. It's great information for us. And to add a little extra incentive, we'll be holding a drawing for those who take the time to complete the survey. We're giving away 2022 complimentary registration to next year's in-person conference. So thank you to the audience. Ford, again, thank you. And we look forward to seeing you at our next session. Take care.